And I think she's compliant with her home exercises. And usually I keep the splint on for 6 weeks, but with her, I might say, can we DC the splint at 5 weeks? Because I need to get her going, or it's not going to matter that her tendon was repaired, right? So it's that communication with the doc that's critical. So here's her protocol. And this is what it looks like when you have a limitation and excursion. So if I can passively take that finger and pop it down, and I let go and it pops back up, that's a limit in tendon glide. It's a limit in tendon glide. I can pull it down there so it's not a joint problem. Remember when we talked about under evaluation, why do active motion versus passive motion? I'm trying to decide, is it a strength issue? Is it a tendon glide issue? Is it a joint issue? If I can take that finger, pop it down, and get it all the way flexed, it is not a joint issue. It's a gliding issue. Because I let go and it pops back up. And that is the most frustrating thing for your patient and you as a therapist, because there's not a lot that we can do. Exercise. Like if a patient has passive range of motion limits, joint limits, there's a ton that we can do to get it to move, right? If they have tendon gliding issues, there's not a ton that we can do. It's on the patient. They have to exercise the heck out of it to get it to glide. I can't reach in there and pull on that string, right? They have to use their own muscles to contract to pull. Sometimes patients aren't as stoic as others, like meaning they can't tolerate the pain. So you mentioned E-stim. So I might use E-stim on the muscle contraction, so it takes my patient's control or effort out of it, and I turn it up and I use the electric current to pull it down. I might do that with my patients to try to increase tendon glide. What else do you think that we could do? This just shows real quick thumb protocol. And this shows blocking exercises, which blocking is critical because this isolates gliding, right? Take your finger and hold it up in full extension and just try to bend the digit tip. It's easy, right? Now flex and try to bend. Hard, right? So if my patient can't bend up here, they're never going to make a fist. So work on blocking first. When it's time, not at day 21, right? But we're going to move them forward and work on blocking. And what the body will naturally do is move what they can move easy first and then try to pull it in the rest. And you've already tried that. When you get down to here and you try to pull it in, it's very hard, very hard. So since most people have zone 2 injuries, it's that getting this movement up here that's critical. And I have a better mechanical advantage. Once I flex my MPs, already a lot of gliding took place, and so flex your MPs and try to pull your fingers in. Try to pull them in. Hard, right? And then go up to a hook and pull down. Easy, right? So we got a block and we got a hook. If you got a gliding problem, block and hook until your patient can't do it anymore. And you can't do that. That's why it's so frustrating for therapists to have patients with tendon glide issues, because I can't do anything. I can just tell you to block and hook and block and hook and block and hook. And you have to do it every hour that you're awake, 20 times, to get the extrinsic adhesions free from the tendon that needs to glide. Another way, if the FDS is not gliding, is to differentially glide. Another way is that sometimes just giving your patient something to grab onto, like moving in space sometimes is difficult for patients, but if you give them something to hold on to, it makes it easier for them to get range of motion. Anything else that you can think of that we learned about that could help with a gliding issue? Besides, we talked about changing the position of the finger to give it a better mechanical advantage to move, like blocking and hooking. right? Yeah.
I mean, if you're trying to break, out tissue, right? You're trying to break up that adhesion. So would other disability modalities,
Yes. So ultrasound, would we want to use thermal or non-thermal?
Not thermal.
Why would we want to use non-thermal?
Not trying to extend tissue.
We are trying to extend tissue. The only way to truly break them up is to pull it apart. And how can I really do that? Exercising, the patient can break them, right? But I can also lengthen them, which might give me enough glide that I can make a full fist. If I can lengthen that scar tissue, that extrinsic scar that forms, maybe I can get enough glide that I can make a full fist. So using a thermal ultrasound over the adherent tissue, followed by hooking and blocking, and 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 more hooking and blocking. Okay? But right after, because how long do the effects of ultrasound last? 5 minutes, right? During. Also, didn't we talk about something that you could use with iontophoresis to decrease scar adhesions? Saline solution at a higher concentration or potassium iodide. You can put over the site where there's adherence and use that to also increase tendon glide. That you would want to do at the end of therapy, because if I do that and then I hook and glide and hook and glide and hook and glide, I'm going to move the medicine out of the area more quickly, and I want it to stick in there, so I want to do it at the end. Yes, you can bill for it. You're billing for the current dionyl, the E-stent. Yep. Okay? There's another thing that we do called, can't think of it. All right, called, okay, I talked about it in clinic, so those of you that were in clinic with me should know what I'm talking about. Oh my gosh! It's I use the race car analogy to describe it. I'm having like word finding problems. I need to get an MRI.
Tendon acceleration.
Tendon acceleration. Thank you, Dave.
Oh,
So tendon acceleration exercises are a way that we can try to break free those adhesions, okay? So I use the analogy of a race car driver. So I've never driven a race car, but from what I understand, you put your foot on the gas and the brake at the same time, and then you pop the brake and you go flying down the racetrack if you drive a race car, okay? So the same thing happens with the tendon. We want to get the tendon gliding, okay? So say I have a gliding problem with my index finger. So see how my fingers all move? I can't just move my index finger alone. They all move together because the FDP is shares a common muscle belly, right? That's why if I cut my index finger, I can't just immobilize that. I have to immobilize the whole shebang. They share a common muscle belly. Okay? So say if I try to make a fist, this is what I got. I can passively flex it, and I let go and it pops back up, right? I'm strong. If I do manual muscle testing, I've been exercising this baby for 5 weeks, every hour, 20 times. It is strong. It's not a strength issue. It's a gliding issue. It's stuck like glue inside there, okay? So I put my brake on. My thumb against my index finger is my brake. And I try to flex against it. It's my gas, right? And I let go, and I try to let go of the brake, just like with the race car. And that force might break free some of those scar adhesions that are limiting glide. Those are called tendon acceleration exercises, which are something else that we can do, have our patients do at home, following flexor tendon injuries. Okay, so that's flexor tendons. All right, flexor tendons I hate treating them because it's so frustrating. Like those proximal zones 3, 4, and 5, they all get great outcomes. But the patients that I get that come for a long time of therapy are these zone 2s that have tendon gliding issues because we weren't allowed to do active range of motion until after day 21. And they have extrinsic healing, they don't have good glide. I don't think we saw anyone in the clinic with this. We had an extensor tendon, but we didn't have flexor. But they're really frustrating to treat because there's not a lot you can do. If they don't get good glide and you've tried everything, they can go in and have what's called a tenolysis. That's surgical. The doctor goes back in later, cleans out all the scar tissue that's keeping the tendon from gliding. There's no immobilization period afterwards. The patient gets moving right after surgery, usually the day after, because they didn't repair the tendon. There is a risk for tendon rupture after that if the surgeon was too aggressive with the flexor tendon. But there is an option. But I don't tell my patients that because some people would be like, I'll just wait later and I'll get a tenolysis done. I'm not doing all this, right? And it's surgery, you know. Most patients that get a tenolysis get a good outcome or a better outcome after. Maybe not a full range of motion, but better. So I kind of hate to start extensor tendons when we only have 13 minutes. So why don't we wait to start extensor tendons next week, and we'll cover extensor tendons and industrial rehab. The industrial rehab is supposed to talk. And then we'll do our team-based quiz that day too. There's both flexors and extensors. For those of you that are able to help me out with data collection, that were inter-rater reliability people,